Hello, everyone. Welcome back to your anatomy lecture. Today, we're going to be taking a look at muscles of mastication. And when I say mastication, be careful because that has a S-T-I-C, very similar to another word, but mastication basically means chewing. So chewing is the movement of the lower jaw, like when you move your lower jaw, or rather when you chew, you're moving the lower jaw, while the upper jaw and the rest of your skull is basically, relatively static, but the thing that's moving the most is the lower jaw. So this is actually a little bit more complicated than it seems. So let's go ahead and take a look at that right now. So the muscles of mastication, well, first of all, mastication is going to include your lower jaw, but also your teeth. But there will be some supportive structures that will be going along with it. So ligaments, as well as some cartilage that's going to be found between these structures. And then we'll talk about some movements, and then finally mass or muscles that help with moving the jaw up and down. Now, very, very briefly, let's just talk about teeth just for a second. So if you look closely, the upper and lower jaw both have teeth in them. So the teeth are going to be found within these little sockets called alveoli. They're going to have joints called gomphoses, and these teeth are hopefully going to stay in there for a very long time. Like you can see that there are little pockets that the teeth will be able to rest inside of, and you do not really want those to be loose. You want those to be very strong, and you want them to stay in there for hopefully forever. But looking at a tooth, there's a little bit of anatomy that you can look at regarding the tooth itself. So although it doesn't show it, super well, actually no, it shows it pretty well. Look closely and you can see that there is a little bit of a division right here, like where you have this whitish tissue right on the outside versus what you have down here, which is the part that goes into the jawbone. So roughly, you have the neck in the middle, but you have the root, which is the part that goes into the skull, and then you have the crown, which is the part that's going to be exposed from to the outside of the body, basically. Now, a couple things regarding the crown that we're not really going to cover too much, but look at the crown and you'll see that there is a whitish layer on the outside, but then it does have like this layer on the inside as well. These two structures have names that you might be a little familiar with, at least the first of which from various toothpaste commercials. The very outside of the crown is called the enamel. So when you look at anyone's teeth, like for the most part, you're looking at their enamel. And their enamel typically, at least usually, starts in a whitish color. And over time, it can get either eroded or diminished. I mean, to the extent where you actually can lose a significant amount of it, but sometimes it also becomes a little discolored. But another way that the enamel, or rather your teeth, can look discolored is if the enamel gets worn down sufficiently, the deeper part, the dentin, which is technically pretty hard, but not as hard as enamel, which, just to be clear, enamel is the hardest tissue that we have in the body. So dentin is a little bit yellower, and if the enamel is worn down, the dentin is going to show a lot more. So I guess just really quickly, you can also see that you have this area in the middle called the pulp cavity. This is where you have the soft living tissues, but then you also have the root canal, which is what allows everything to connect to it. So if, you get an infection inside of your tooth, you might need to get a procedure called a root canal, where you basically kind of take out all of this tissue and then replace it because you do not want that infection to get all the way down into your mandible, and you do not want, an infection inside of your bones. So that was quite a bit of teeth, but we just have a little bit more to talk about. So if you look closely, the teeth do rest inside of the mandible and maxilla. These are joints called gomphoses. These are synarthroses, meaning they do not move. These should be very, very strong. Now, lastly, regarding teeth, there are different types of teeth. You can see that you have incisors, canines, premolars, and molars, and you have different numbers of them. But not just that, they're also going to have different functions. So to break it down very quickly. So if you look closely, you have central and lateral incisors, and you have two or one for every quadrant. So two top central incisors, two bottom central incisors, two lateral or two lateral left and right incisors for the top, and then the same for the bottom. So with that said, you have a total of eight, but these are the front teeth basically. Like when you look at someone's front teeth, like they should be somewhat flat. I mean, I think you know what flat or incisors look like if you've ever seen someone's front teeth. They look like flat, but the way that I like to describe them is that they look like little chisels. They are flat, they are wide, but they're also very thin on one plane. And that allows you to kind of slice things or chop things much more easily, which is what incisors are meant for. Like they're meant to break things down very quickly before they enter the mouth, which if things enter the mouth, you then have these little things called canines, which are right along the side of them, which are slightly different in that they are a little bit pointy. So what we're going to be talking about for the rest of the teeth is that there are little bumps on the teeth. Canines only have one. And canines are the ones that if, they happen to be especially, pointy, they could look like fangs, but we don't really have fangs. So, but other animals do have fangs, which would be analogous to our canines. So canines only have one hill, one bump. They are a little bit pointy, but next you have two sets of premolars. So premolars have another name, which is called bicuspids. And what that means is that they typically have two hills. So they would have one hill on the front, one hill on the back, and then these would be your premolars. So your premolars have two hills rather than one hill for the canines. And then lastly, molars. They have a bunch of hills. Like they could have various numbers of hills, and a lot of them or like a lot of them, in fact, because these teeth are not necessarily for like, slicing and chopping and doing things like very precise kind of segmenting. This is mostly for crushing. So crushing, as in like grinding and crushing to break down things as into little tiny pieces. And that's basically what the molars do in the back of your jaw. So you can see that you have incisors, canines, premolars, and then molars. And just to be clear, those wisdom teeth, would be like your back molars. So sometimes those teeth will come up and potentially push on your other teeth, causing them to get a little bit misaligned and cause a lot of pain. So if that happens, it's not necessarily, required, but if it does happen, you can take those out and you should be perfectly fine. So let's go ahead and talk about the joint of the lower or of the jaw, which is going to be called the temporomandibular joint or the TMJ. So the temporomandibular joint is a very mobile joint compared to, well, all of the rest of the skull. The rest of the skull, you want to generally stay or have things stay in place for the most part. But for the TMJ, this is a diarthrosis. This is a synovial joint. And this is a hinge joint technically, but it does have the ability to actually kind of dislocate slightly and translate, as in like it could actually kind of come out and glide along like the outer part of this joint and allow for some amount of like protrusion, retraction, and then a little bit of rotation through pivoting. So it's going to be a little bit unsettling to see, but it happens all the time. So it's pretty normal for the TMJ to be able to do that because anytime that you open your jaw really wide, like believe it or not, you are actually having your mandible kind of come out of that TMJ ever so slightly. Now, to talk about some supportive structures really quickly, you can see that we have a little list here, a few different ligaments, and then some very important, or a very important part, which is the articular disc, and then the joint capsule, which is very typical. So let's go ahead and take a look at these one by one, starting with the joint capsule. So the joint capsule, I mean, it is a synovial joint. It's going to be covered by a joint capsule. And you can generally see that, I mean, it's surrounding the whole head of or the whole head of the mandibular condyle, and then going over to the mandible, or sorry, the temporal bone. And it is also going to have a synovial membrane, which is typical for a synovial joint. And it's going to be lining the inside of this joint, but it will not be found right along the articular surface. So it doesn't cover the articular disc nor the articular surface, which is right in the middle. Now, speaking of the articular disc, this is something that's kind of important for the TMJ. This is going to be a little shock absorber, which is called, well, which is made up of something called fibrocartilage. This is where or this is something that allows the TMJ to be a little bit more mobile, not just like mm, statically sitting there. Like this will protect the inside of the joint. It'll protect the areas between the bones. And it does also, to some extent, help for a little bit of sliding as well. So in this case, it'll be connected to something called the retrodiscal lamina. But then on the anterior side, there'll be a muscle that we'll talk about called the lateral pterygoid, which will connect to it on the other side. So the lateral pterygoid you can see over here, but I don't think you can see the retrodiscal lamina on this. But you'll be able to see the articular disc right here in the middle of the TMJ, right between the mandibular fossa and the condylar process of the mandible. Now, just to be clear, there are ligaments here too, just like most of our joints, but we have a few named ones that we do want to be aware of. And luckily, as usual, they are named for what they connect. So a lot of these are going to be to the mandible, but either from the temporal bone, first of all, temporal mandibular ligament, or known as the lateral ligament. You can see that right over here, connecting between the head of the man or the condylar process or mandibular condyle, and then going all the way up here towards like the temporal bone. So connecting to the zygomatic process and down to the condyle of the mandible. Oh, sorry. Over here. This is going to be the zygomatic process right over here, going to the condylar process right over here. So this is the lateral ligament of the TMJ or the temporal mandibular ligament. And you can also see its two different fiber orientations, the transverse versus the oblique. And this is going to help with supporting the TMJ in slightly different ways, which is either restricting retrusion, which is like making sure that it doesn't go too far back too quickly or too far back at all. And then the oblique head helps to support it during a little bit of translation, which is when your jaw opens up really widely. But then two more types of ligaments, not, okay, one of them does connect to the temporal bone still. That is called the stylomandibular ligament, and stylo is meaning or referring to the styloid process. You can see that right down here, this really skinny ligament. This is going to be connecting to the angle of the mandible right at the bottom of the ramus. And this is very skinny. Like it doesn't really do a whole lot, but it's there. But lastly, you have what's called the sphenomandibular ligament, which you'll be able to see right over here. And this is connecting between the sphenoid bone and the mandible. So once again, when you are opening your jaw very widely, this is going to become taut or tight or have tension in it due to its location and being able to support it. So with that said, let's talk a little bit about jaw movements really quickly, because this is actually a little different from what some people understand. So first of all, I mean, elevation and depression is very normal. Like that's exactly what people think of when they think of the mandible, but there is even a little bit more to go along with that as well. But in addition, there's protrusion and retrusion or protraction and retraction. This is just moving the jaw forward or back and then back into its normal position. And then lateral protrusion means that it can move to the side, actually. So so that's a little bit of what's known as pivoting, but that's a little different. So let's take a look at these real quick. So first of all, when you have the mandible closed, this is very, the most stable position. This is what you'd expect the mandible to do whenever it's sitting with the rest of the skull. The head of the mandible, or sorry, the condyle of the mandible or the mandibular condyle, the condylar process. It sits right inside of the mandibular fossa. And this is exactly what you'd expect for most joints. Condyle fits in fossa, and they rest together very, very well. But when you open the jaw, I mean, number one, you can open the jaw, and that actually can stay the same. It can just, open the jaw with the TMJ intact. But if you open the jaw too widely, as in like really big, that is where you'll actually have a little bit of protrusion along with the depression. So if you look closely, the mandible actually comes out a little bit with the articular disc. This is going to be allowing the mandible to open up wider than it usually would, like farther than its just stable range of motion, but that requires it to come out a little bit from the fossa. So if you look closely, you can depress the jaw, but also protrude the jaw, which is pushing the jaw forward, but that is also used when opening your jaw very widely. But the other two here that we have is protraction of only one side, which is going to cause some amount of pivoting. So when you like bring your jaw to the sides, that is going to be keeping one side intact, but then pivoting that one side, causing protraction or protrusion of the other. So if you move your jaw to the right, you are rotating the right side and your left side comes out. And then vice versa for the other. If you move your jaw to the left, you are rotating the left side and your right side comes out of the TMJ. So just to kind of give you a little bit of specificity to these movements. So the first phase of opening your mouth, as in like depressing the mandible, just to be clear, this is going to be the first 35 to 50% of the range of motion. So when you open the jaw, you can see that it goes downwards, and it can do that for about, 35 to 50% of its total range of motion. And what that means is that, or what I'm talking about here is where the TMJ is still intact, where the mandibular fossa and the mandibular condyle are still kind of all together. And the condyle basically just rolls along the fossa in a very typical joint fashion. But when you do a little bit more depression, you're going to require a little bit of protraction to go along with it. So in this case, when you have your jaw opening wider than normal, or not normal, but wider than what the condyle can handle, it will need to actually protrude and then and then allow for the jaw to open even wider. So you can see once again that, well, looking at this little animation, you can see that the condyle actually comes out a little bit from the fossa, and that's allowing the jaw to open up even more. So the rest of it, basically, the further 50 to 65% of the total range of motion, that's going to be due to this second phase where it requires a little bit of that protraction or that protrusion of the jaw as well. So, believe it or not, it does happen. You can see that here, where you have the mandibular fossa as well as the condyle. And when you depress the mandible sufficiently, it will actually require you to have that condyle somewhat exit the fossa to allow for a little bit more range of motion. So, with that said, let's go ahead and take a look at the muscles that do this. And once again, be careful because some muscles will help with elevation, while some muscles will help with depression of the mandible. And both of them will be required in order for you to be able to, open and close the jaw. Um, this is going to be, or this is going to be important for chewing or mastication, but just be careful of what direction it's going to do that for. So to start off with, and hold on, I think I have an alarm that's going to go off. The first muscle that we have here is called the temporalis. So the temporalis, its name is very indicative of where you find it. Temporalis, it's on the temporal bone. And if you look closely, it's basically all along the temporal fossa, right along like the temporal lines of the parietal bone as well. So if you look at the temporalis, though, it has most of its muscle here, but where is it connecting? Like this is a little bit of an interesting thing because it is actually going to connect down here under the masseter, or under another muscle called the masseter, right at what's called the coronoid process. So you can see it connecting to the coronoid process along the anterior part of the ramus, that pointy part, the beak part, right in the front. But since it's connecting to the mandible, it can help with moving the mandible and looking at the orientation of these muscle fibers. When it contracts, it pulls the mandible upwards. So that's going to help with elevating the mandible and then also to some extent a little bit of retraction. So it helps with elevating the mandible, retraction of the mandible, but then when you ipsilaterally contract it, or sorry, when you unilaterally contract it, you will have what's known as ipsilateral excursion. So this is going to be a part of the rotation, the pivoting part. So when you only contract one, you can actually help with that pivoting, that rotation of the jaw where one of them or one side comes out and one side rotates. So just to kind of be clear, ipsilateral means that whatever side is contracting, the movement is towards that side. So bilaterally, elevate and retract the jaw, unilaterally, ipsilateral excursion. And while we talked about facial nerve a lot before, in this case, it's mostly going to be trigeminal. So trigeminal, cranial nerve 5. In fact, I mean, don't forget that. Trigeminal, cranial nerve 5, and then mandibular division, which is CN5 through 5-3. So I won't retype that for all of them, but just to be clear, that's what it means. Trigeminal CN5, mandibular division CN5-3. So temporalis, you can see that it's going to connect to the mandible and look at the orientation of the muscle fibers to help with knowing what it's going to do and what direction it's going to be moving. Oh, sorry, one last thing. I mean, this is actually something that you probably have experienced. I mean, when I say experience, I mean, you probably have felt it. So go ahead and put your hands or fingers on the side of your head and just gently clench your jaw a little bit. Do you feel a little bit of that muscle? Or you probably feel something at least, but the temporalis, it is on the side of the head. Now, if you do that again, you can probably feel this muscle on the side of your jaw as well. This is called the masseter. So the masseter on the side of the jaw, this one, just like the temporalis, same orientation, same kind of connection even, but just different places. If you look closely, not on the temporal bone, this is actually connecting from the the zygomatic arch, a little bit of temporal process, a little bit of zygomatic process, but it is going to go down and slightly diagonally, but it's going to connect to the bottom of the masseter. And I would say this muscle is one of our primary muscles for chewing. is going to very strongly elevate the jaw. So it elevates the jaw as well as does a little bit of protrusion because once again, that slight oblique angle helps with pulling the jaw a little bit forward. So both elevation and protrusion bilaterally, but then once again, unilaterally, a little bit of ipsilateral excursion. And something that you'll see is that most of our muscles will be innervated by trigeminal CN5, mandibular division CN5-3. Now, here's a couple muscles that we don't really see very often because it's kind of deep, but if you look closely, we have these muscles along the inside of the jaw as well. So these muscles are connected to your sphenoid bone, which is on the pterygoid processes, and these are going to be called the medial and lateral pterygoid muscles. So in fact, to start off with, coming from the lateral pterygoid plate, this is where you're going to find medial pterygoid muscle, which you can also see in here as well. And looking closely at this angle, you can see it connecting at a diagonal angle, connecting right along the inside of the ramus. Now, once again, looking at that angle, what is it going to do? It pulls the mandible upward as well as a little and causes a little bit of protrusion. So upwards and forward, but once again, excursion. But in this case, when one of these contracts, it actually causes the excursion to move in the opposite direction. So instead of ipsilateral, this is called contralateral excursion. So just to be clear, when you contract your right medial pterygoid, your jaw moves to the left. So it's hard to kind of like visualize, but imagine contracting this muscle only. That means that this muscle will move, or sorry, this part of the mandible will move forward, this part of the muscle, or this part of the jaw will not. So this moves forward and it rotates this direction. So when I contract the right side on the inside, it's going to pull this side forward, and that's going to move the jaw in this direction. So I hope that's clear. If that's a little hard to understand, I'll try to find a better way to explain it, and please ask me later. But in addition to medial pterygoid, you have a lateral pterygoid. So lateral pterygoid is a little different. I mean, different in just its location and orientation, but you can see that, well, just to compare, the lateral pterygoid, okay, maybe a little hard to see from here, but okay, down here. Oh no, you can see them actually really well. So these are the lateral pterygoids. They're a little bit more or much more horizontal and even slightly more, well, yeah, much more horizontal. So if you look at the pterygoid, there are actually two parts though, a superior and an inferior head. And this is going to be connecting to the mandible as well, right along the neck of the mandible underneath the condyle, but then also kind of connecting to the capsule of the TMJ as well. So this, when contracted, will actually help with depressing the jaw. Because when you depress the jaw, remember, it's not just, mm, it's not just moving the jaw like down this way. It's also protruding the jaw out of the TMJ. So when you are depressing the jaw to that really wide extent, you're going to be protruding the mandible, which is bringing the condyle outward. So to do that, the lateral pterygoid will do, or will mostly help with that. So this is a little bit different from the rest of our muscles so far because it helps with depressing, which is mostly like in the wide depression, which is helping you to really open your jaw. And then contralateral excursion, same thing, where when it contracts, the opposite side is going to rotate. And then still mandibular CN5-3 of trigeminal CN5. So you can see those here, lateral pterygoid and medial pterygoid connecting to the pterygoid processes coming down from the sphenoid bone, which you can see the lesser and greater wings and the pterygoid processes extending downwards. Now, believe it or not, we don't just elevate the jaw, we also depress the jaw, and there's muscles that do that as well. So if you look closely, you have muscles such as the stylohyoid, the digastric, and then the mylohyoid, and then more digastric. There is one more muscle that's not really visible, but that's called the geniohyoid, but I'm only going to talk about these very briefly. So these are very important, but they're really small. So I'm hoping we're going to be able to at least see some of them on the cadaver. But to get started, there's actually a bone that we haven't really talked about. If you look closely, we have a bone called the hyoid bone. And the hyoid bone has a U shape or U shape kind of shape, and it kind of looks like a horseshoe. But if you look at the hyoid bone, there's just a couple little points on it, the lesser horn, the greater horn, and then the body right in the middle. So an interesting thing about the hyoid bone, though, is that it doesn't really have a lot of articulation to any bones. In fact, zero articulations to any bones, but it will be connected to other things via ligaments and tendons. So in this case, you can see it's connecting to the voice box, actually called the larynx. This is where the hyoid bone kind of sits right at the top of the neck and the back of the chin, all the way up here. So, uh, fun fact about the hyoid bone. The hyoid bone only really breaks in one case, or actually maybe a few, but it's very niche where the hyoid bone is going to break. And typically, this can be used for forensic science because, I mean, usually only kind of one type of assault causes any damage to this bone without catastrophic bodily injury, but it's usually when you're choked. So hyoid bone, it's up here. And if you are choked, that's kind of one of the only times where the hyoid bone might break. But enough of that. Let's talk about some things that connect to that. And these muscles, I forgot to mention, are called suprahyoid muscles. So these are actually above the hyoid right here. And then you all have infrahyoid muscles, which we'll talk about a little later. So the first muscle that we have here is one of the primary ones, actually called the digastric. So if you look at the digastric, it's going to actually have two parts to it, an anterior and posterior belly. This is going to allow it to connect to two things. Oh, well, actually three things, technically. So they're both connecting to the hyoid bone, but then they're connecting to the mandible along the anterior belly, and then it's connecting right along the inside of the mastoid process for the posterior belly. So right back here. So it'll go from the chin to the hyoid and then back. So this is the digastric, and this is connecting to the mandible from an inferior orientation, meaning that when this muscle contracts, it's actually going to pull the jaw downward and open the jaw instead of close. So this helps to depress the mandible, but also elevate the hyoid. Now this actually has two innervations. The anterior belly is innervated by the mandibular CN5-3, as usual, but then the posterior belly is innervated by facial CN7. Now, from here on out, a lot of the rest of the names are going to be named for its connection to the hyoid, so these hopefully will be a little bit more intuitive. So the next one that we have here is called stylohyoid, and this is a tiny muscle. Like if you look closely, it's really small, even comparison to digastric, and you can see that right here where the stylohyoid is just going to be connecting between two things. Styloid process of the temporal bone, and then hyoid bone. And this is going to help with, once again, elevating the jaw, and then also holding the jaw posteriorly and innervated by facial CN7. Give me one sec. Okay, let's try and finish this. Um, stylohyoid and digastric, very closely in orientation. And then one more muscle that's very close to here as well is called the mylohyoid. So the mylohyoid, if you remember, there is something called the mylohyoid line right along the inside of the mandible. And finally, we can use it, I guess, where if you look closely, you have this muscle that's actually going to be connected along the inside of the mandible, but not just, at one point, but right along that kind of like ridge, not just like one point, but along the inside. And in this case, it's also connected to the hyoid bone, which you can see right here, connecting at the body. But although not shown very well, do I have a better picture that shows it? Not really. But basically, this helps to form the floor of the oral cavity. So the mylohyoid actually forms like a broad area along the bottom of the jaw, and it's essentially the floor of the oral cavity. So here, I'm gonna briefly steal this image. I mean, not steal, borrow, utilize. But if you look closely, here's the mylohyoid. You can see that it's connecting along the mylohyoid line of the mandible, and then it connects to the body of the hyoid right down here. Now, the thing that I also want you to note, though, is that it is going to be in close proximity to another muscle, which is the digastric. So typically, oops. So typically, the digastric sits kind of right along it, and you can see the mylohyoid underneath in kind of red, and then the digastric, which is superficial to it, runs along the top of it, or the bottom of it technically. So when you look at these muscles, when you try to orient yourself, when you look for it on, the cadaver or models, that's how you find it. Mylohyoid is directly deep to the digastric, and this, as usual, helps with depressing the mandible, elevating the or the hyoid, but it also is the floor of the oral cavity. Now, one more muscle to look at here, and this is called the geniohyoid. So the geniohyoid, it's a kind of small muscle, but you can see that right here is connecting between the mandible to the hyoid once again, and this is going to help with depressing the mandible. So similar to digastric, but this one is a bit smaller, although a little bit more, simple and straightforward. And this is actually deep to the mylohyoid, so it's even harder to see. So sometimes the geniohyoid, or oftentimes the geniohyoid won't really be very visible, but at the very least, you can see it here where the mylohyoid has been removed. So just to be clear, this is not digastric. This is not, making that V shape. This is just going straight from mandible to hyoid. This is geniohyoid. And to throw in a new curveball, it is innervated by hypoglossal cranial nerve 12. So this one is just slightly different, and this is going to be a different cranial nerve. So you can see that you have a variety of different muscles that are going to be, ooh, what the heck? You have slightly different muscles that are going to be helping with depressing the mandible in addition to elevating. So depending on what side, whether it's from the top or the bottom, that's a good indication of what direction it's going to move. But just to very briefly kind of recap, if you look closely, you have various muscles that will help with doing all of these actions. So elevation of the jaw, closing the jaw, masseter, temporalis, and medial pterygoid. Opening the jaw, or sorry, uh, yeah, opening the jaw even more. You have the suprahyoid muscles, and this as well as the lateral pterygoid muscles. So lateral pterygoid for opening the jaw widely, and then suprahyoid, like all of those muscles down here, for generally all of the opening of the jaw. And then for protrusion, lateral pterygoids, medial pterygoids, and masseter. So anything that has a slightly anterior orientation. protrusion, anything from the back, temporalis coming from this area, and then suprahyoid muscles again can help with retraction as well. And then excursion, lateral excursion, or sorry, lateral excursion, which is like moving the jaw to the sides. You can see that the jaw actually does kind of misalign when it has excursion, and anything from a side, like anything along the side of the jaw, generally does that. The pterygoids, the masseter, and the temporalis. And then once again, most of everything was innervated by mandibular CN5-3 of trigeminal CN5, and that's going to be innervating most of those muscles. So the TMJ is actually something that does actually come up a bit in, like, different, I guess, circumstances, but there are some issues that can happen with the TMJ, and it can depend on a lot of different things, whether it's clenching the jaw when you sleep or different kind of postures of the head, stress, oral habits, and muscle asymmetry. So depending on, the issue, it can actually affect the TMJ and the jaw. But lastly, you actually can dislocate the jaw as well, although somewhat rare compared to some other injuries. Your jaw can come out to the extent where it cannot close again. So if that happens, I mean, you just kind of need to go get it fixed. But yeah, sometimes you can have dislocation or subluxation to the extent where it just cannot go back. So, it's very normally comes out of the mandibular fossa, but usually it slides back in along with that articular disc. So I think with that said, that should be it. Yeah. Thanks for listening. Good luck with your studying, and I'll see you all next time.